welcome you all again. I'm Janet Porter. I am a Training and Technical Assistance Coordinator for the Pacific Southwest PTTC. We also have staff joining as well today from the Mental Health TTC, and they are running the tech platform for today's webinar. So we are pleased to bring you this joint event for both of our TTCs in the Pacific Southwest. So welcome. Please note that this webinar is being recorded today. If you register for the webinar, you will receive the recording and the slides after the webinar. You can also download the slides directly from the handouts pod, and you'll find that in the bottom left corner of your screen. And you can go ahead and click on that file, and you should be able to download it directly. You will also receive a certificate of participation today for 1.5 hours of continuing education credit, and that will be sent to you from the Pacific Southwest PTTC. Also note that the views expressed in the webinar today do not necessarily represent the views, policies, and positions of SAMHSA. So this is a map of the technology transfer system across the country. If you're not familiar with the TTCs, it is a national system. You can see here that each region across the country has a PTTC, an ATTC, and a mental health TTC, and those are represented here by the various colors. PTTCs are in green, the mental health TTCs in red, and the ATTCs in blue. And then the Pacific Southwest region is located in Region 9. So here's a bit of a closer look at our Pacific Southwest region. This includes the states of California, Nevada, Arizona, Hawaii, and the Pacific jurisdictions. So as you can see, we have a pretty large and diverse region out here in Region 9. The Prevention Technology Transfer Centers serve as a resource to those of you in the substance misuse prevention workforce. We are a source of information for prevention professionals, and we work to develop tools, resources, training, and provide technical assistance to assist you with your substance misuse prevention efforts. And similarly, the mental health TTCs have a similar scope. They provide training and technical assistance and resources to support the mental health workforce, to help them adopt evidence-based practices across the mental health continuum of care. They also promote evidence-based, culturally appropriate mental health prevention treatment and recovery strategies for providers and practitioners. And here's kind of a snapshot of the services offered by the Mental Health TTC, and we have similar services as well that are offered by the PTTC, including webinars, newsletters, online courses, etc. So please reach out to either center if you have an interest in these services. So it's now my pleasure to introduce our presenters for today's webinar. We have Brett Harris joining us. She's a clinical assistant professor at the University of Albany School of Public Health and the Director of Public Health Initiatives at the Suicide Prevention Office of the New York State Office of Mental Health. She is joined by James Mazza, who is a professor of educational psychology at the University of Washington and director of the school psychology program. And we are also joined today by Deborah Cox-Howard, who is a mental health clinician at the University of Arizona Counseling and Psych Services Department. We have a great panel of presenters today, so I want to thank each of them for presenting, and I'm going to turn it over to you, Dr. Mazza, to get us started.
Hopefully you can hear me. So thank you, everybody, for attending.
Yes.
I thought I would kick us off and give us a little bit of background regarding the theories of suicide and how suicide is a problem that seems to be increasing in the last 10 to 15 years. And so what I want to show here with this first slide is that you can see suicide here. Let's see if I can use my arrow. Is the second leading cause of death now in ages 10 years old, that's 4th grade, all the way to 34 years old, and it's the fourth leading cause of death from 35-year-olds all the way to 54-year-olds. And so we've got a significant issue here regarding suicide. We're seeing it increase more and more. It is one of the top 10 causes of death here, and out of the other 9, suicide is the only one going up. The other 9 are actually coming down. So whatever we're doing seems to be not working. And so I know that we've got a lot of people that work in the area of suicide and suicidology. They pour their heart and souls and passion into it, and we still need to get kind of a better idea of what's happening and why are we seeing an increase. And so maybe understanding some of the theories and what goes into those theories may help us a bit. So one of the things here I thought I would show you is that we've got a chart here that shows some of the risk factors. That's what's in red here. And I want to highlight that our drug and alcohol misuse sits over here as one of our risk factors. It is also part of our co-occurring disorders that we know that happen for individuals who attempt suicide or who die by suicide. And so, drug and alcohol misuse happens with people that have anxiety or depression or schizophrenia or some of the other mental health difficulties that we have. And so important to see what that is as a risk factor. Also, we see here when we bring up the black letters that effective treatment for mental, physical, and substance abuse disorders is also a protective factor. So when we can identify substance misuses, it's important for us to provide proactively treatment or to have a way of helping our individuals who are misusing the substances to intervene. So what we're trying to do is to reduce the severity of their misuse so that we can actually reduce the severity of their suicidal ideation, their suicidal behaviors. All right, and so that becomes important. And one last one that's actually a protective factor sits right here at sobriety. And so that we know people who are using less, who are actually sober, have decreased a risk factor for suicidal behavior in that regard. Plus, it also helps reduce our emotional dysregulation, which I'm going to cover in just a little bit. So what is this relationship between substance use and suicide? And on the surface, we'd probably mainly agree, yeah, certainly there's a relationship that's there, and it seems kind of simple. Yet under the surface of it, it's a much more complex relationship than it looks like. And there are direct effects as well as indirect effects that happen because of substance use. And so we do know from research amongst those who are thinking about suicide, those who attempted suicide, and from those who have died from suicide, when we come back and do psychological autopsies, that there's an increased risk of suicidal behavior in those that use short-term and long-term. In the short term, using substances actually impairs our decision-making ability. So we don't make the decisions, our cognitive function kind of goes offline, all right? So we also lower our inhibitions when we're either drunk or high or stoned, whatever we want to call it. We don't have as many natural inhibiting factors, which actually protect us. It also lowers our impulse control, and so we're more likely to give into impulsivity. We're more likely to carry things out that we normally wouldn't because of our state of use or misuse at that point. And then we've got self-medicating that's taking place. And this especially happens amongst our adolescents and young adults where they're in a lot of emotional pain and they want that emotional pain to go away, so they self-medicate to kind of dull the sharpness of the pain. They kind of become numb, or they use this to check out and become just to be a distraction. So they're going to use these substances as kind of a way to put the reality away from them, right? So they're not dealing with the reality. So in red here, I highlighted that these things can lead to increased likelihood of engaging in suicidal behaviors, all 4 of these things. In the long term, so use, misuse, overuse, addiction, these are negative effects that affect our neurocognitive ability. So people that have been using for quite a while, people that are addicted, they're not functioning well with their cognitive abilities. They're much more worried about getting their next dose, what their emotional pain might be when they come back. And so their prefrontal cortex and their neurons have been damaged by the long-term use that's happening here. And so that can recover. It's just a matter of reducing the amount of use that's happening at that point. There's a lack of behavioral control. And so people that are long-term users and misusers have more difficulties managing their own regulations and managing their behaviors. And then there's underdeveloped regulations. And this is important because we as adults and we as working with some of the kids as well, we're trying to help them develop emotion regulation strategies and coping strategies. And use and misuse of alcohol and substance uses provide an underdevelopment. We don't get a chance to develop some of the control that we would have. And that impacts, so it impacts aggression, sensation seeking, and impulsivity. So we would call those under-controlled areas. All right, so that means that they can't grasp enough of their self-deciding abilities, right, their decision-making abilities, to prohibit the aggression, to prohibit the sensation seeking and impulsivity. And these things lead to this last point down here, that the lack of ability to control some of those areas leads to indirect contributions to development of school failure and peer relationships. And we know for at least adolescents, school is a very important bonding environment, and peer relationships is something that our peers turn to, especially adolescents, as more of a social support. So the lack of school bonding and the lack of peer support automatically puts our adolescents and young adults at increased risk for suicide. So the complications happen here. So that was short and long term. Complications happen here from the role models, right? We've got families members who use and misuse. We've got peers who use and misuse. And so our kids being exposed to parents, even if they're modeling appropriate alcohol use, they still see that as a social thing, something that they can do and they're supposed to do as an adult. And some of our 15 and 16-year-olds who want to become adults or who want to think that they're adults are going to start using that way. There are peer socialization issues that happen here where in order to be with the in crowd or the cool crowd or the whatever crowd it is, having to use is part of the way that you are either initiated in, or it's the actual, what the socialization engagement issue is around. And so hanging out at a party, you're going to use. And so that becomes something that then is much more ingrained as a way of socializing. All right. And so substance use and misuse become more of a core issue that way through indirect exposure. And then we have also pharmacological uses, right, where we've got selective serotonin reuptake inhibitors, that's what SSRI stands for, and that we've got some of our adolescents, our adults are on these antidepressants and anti-anxiety medications. So some drugs are okay while other drugs are not. What's the slippery slope that's there? And so why are some drugs not okay while other drugs are? And so it kind of sends a mixed message to our youth. And so what I want to highlight here is that we've got direct and indirect consequences of misuse that lead to emotional pain. So when kids aren't using and they get rejected from their peer group, that leads to emotional pain. When kids are using and they have lower impulsivity and they feel like they do something that's out of their normal behaviors and they're embarrassed and feel guilty, that also leads to emotional pain. And that becomes important because emotional dysregulation is a core component of both suicide theories. So let me start off with Thomas Joyner's theory of interpersonal theory of suicide. So this is what's called IPT. There are 3 concentric circles here that all overlap, and it's not until you get to the very center of all 3 circles is one at risk for a serious suicide attempt or death by suicide. So let's unpack these. Thought of belongingness is the ability of being rejected and trying to join a group, trying to be bonded to school, trying to be a member of a peer group that you'd like to belong to, or even being not making it like a sports team or an activity group. All right. Perceived burdensomeness is the idea, the perception of our adolescents and young adults who believe that their life is now a burden to their friends, a burden to their family, financial burden, and so it's difficult for them to perceive how they're contributing. All right. So there's increased costs for therapy. There's increased costs for medications. They keep seeming to be getting in trouble. So they perceive themselves and their lives as a burden to friends and family. And then finally, the capacity to engage in suicidal behavior. So this happens where you have to go against the natural instincts of your body to do something that would actually put you at risk for dying. Because most species have an inherent risk for one to stay alive, not to die. So this capacity to engage in suicidal behavior goes against some of that natural risk. And so we're going to kind of pull that apart, that the thwarted belongingness, where do we see that? Lack of relationships, school bonding connectivity, and then after-school activities. Those are the areas in which, if someone's at risk for suicide, they lack these pieces, all right? On the perceived burdensomeness side, it's providing stress to the family, mental health difficulties that might be experiencing, financial burdens, and then the perception of hopelessness, that they feel like, I'm never going to get out of this. And finally, the capacity to engage in suicidal behavior. They've already are starting to engage in high-risk behaviors. It could be drug misuse, so there's where substance misuse comes into play. It could be engaging in already what we call non-suicidal self-injurious behaviors, NSSIs. Our adolescents and young adults gain comfort with lethal means, so that it's no longer a scary thing. They feel comforted by using drugs or maybe holding a weapon. And then repeated non-lethal attempts. And so they've engaged in suicide attempts before, and they just keep engaging in more and more. And so that's how the IPT theory is used, and where emotional regulation is in the center. And so when all three of those things are present, we sit right here in the center of where someone would make a serious suicide attempt. The other theory is David Klonsky's three-step theory, where the plan actually is, where the first step is pain and hopelessness. The second step is you have this pain, does it exceed your connectivity, right, your connectedness, which we heard in Thomas Joyner's model, and then do you have the capacity? Again, a similar overlap to IPT. So when we apply the emotion regulation or emotional dysfunction, emotional pain onto this theory, we get this situation. Are you in pain and hopeless? Emotional pain, that's the dysregulation piece, all right? And so that's difficult for a lot of us. We are actually much better at dealing with physical pain than we are emotional pain. And what we tend to do is engage in self-harming behaviors to lower the physical pain, to lower the emotional pain so that we experience physical pain. And if we can take our minds off of the emotional pain because we have to deal with the physical pain, it actually reduces it, similar to what an aspirin does for a headache. When you take aspirin, the severity of the headache goes down, so you're more likely to take it again because that behavior gets reinforced. Does the pain exceed your connectivity or your connectedness? So that's emotional pain that we had up here. Up here, whoop, let me grab that. Up here, does it now exceed that? And if so, then we've got a lack of protective factors. So now we've combined emotional pain with the lack of protective factors. And finally, and if that's a yes, we come down here, do they have the capacity? So now the formula is emotional pain plus lack of protective factors plus the ability to use lethal means. That's when we get into making this suicide attempt and engage in lethal suicidal behaviors. If that's a no, that you don't have the capacity, then most of our youth simply are here at ideating. And we still want to engage and intervene in the ideating behaviors because they're still experiencing emotional pain. We just don't have to be, it's not just an eminent concern that it could be happening in the next 3 minutes, the next 3 hours, or the next 3 days. All right, and so that's David Klonsky's model. They both show quite a bit of overlap. Emotional pain sits in the heart of both of those models, and it's one of the underlying pieces that's in Marshall Linehan's model of dialectical behavior therapy, or what we call DBT. So, in summary, the relationship of substance misuse has a direct and indirect effect on adolescents and young adults, substance misuse and suicidal behavior. Substance misuse can cause short and long-term consequences that lead to emotional pain, and that's significant. That emotional pain is that driving force. Emotional pain is at the core of both suicidal behavior theories and models. Thus, strategies and coping skills that reduce substance misuse provide an upstream approach. So one that happens in schools, or it could be in community agencies, that's upstream before they even engage in any suicidal behaviors for youth suicide prevention programs. So that's an ideal place for us to talk about youth substance use as part of the suicide prevention program. With that, I think that is me. I am going to turn it over to Brett.
Hi, everyone. Thank you, Dr. Mazza. So I think this was a really good lead-in to my presentation. I'm going to be talking about integrating suicide prevention into the SBIRT model. So I really wanted to, I have, a background in SBIRT, and then when I kind of came into suicide prevention, I realized a lot of similarities to the model, and I think that the SBIRT model has become more robust in recent years, and it's really critical based on Dr. Mazza's presentation that suicide prevention be integrated with substance use prevention and early intervention. So I just wanted to begin a little bit talking about self-injury mortality. So we know that the opioid epidemic, is really has a lot of attention. It's opioid overdoses have been increasing. This is really a tremendous public health problem. And suicides along with that have been steadily increasing as well. And if we look at them together, we call it self-injury mortality. It's a really large number, and it gains a lot of attention and where it should be. This is a major public health problem. We also know that the number of suicides are underestimated. The estimate is that about 20 to 30% of suicides are misclassified as unintentional overdoses. It's very difficult to label an overdose as a suicide if there's not a suicide note with it. So we know that that steady rise of suicide actually is probably larger than the data show us. So what this really underscores is that suicide prevention should be seen as substance use and or opioid overdose prevention. It really may be kind of that missing link in the response to the opioid epidemic. So I'm just going to give a very quick overview of SBIRT, as I don't know where the audience kind of where you all are in your understanding and knowledge of SBIRT. But the current model addressing substance use is really something you say good or bad. So the green light, that's go. So abstinence or responsible use, and then there's addiction. So that's something we need to address in that red circle. So SBIRT is evidence-based prevention and early intervention model. Its real goal is to address the full continuum of substance use. So not just, as you'll see on the next slide, there's a big gap there. So not just, prevention among those who haven't started to use, and then treatment for those who have an addiction. It's screening, brief intervention, and referral to treatment. And the screening is a standardized, validated tool that provides an algorithm for identifying the proper level of intervention, whether it's just positive reinforcement for someone who's screening negative, someone who's screening at risk, having a brief intervention, or someone who is scoring at a high level who needs to be referred for further assessment and may need treatment. So the goal of SBIRT is to identify at-risk substance users in non-substance use disorder treatment settings. So we're not looking, this is not a form of treatment. It's to really identify individuals where they're going. And we know that there's a lot of, there are people that have substance use disorders or problem use that could benefit from treatment and aren't getting it. So those people need to be identified in non-substance use disorder treatments such as primary care settings, emergency departments, school-based health centers, schools, college clinics, and so forth. And then provision of appropriate services right on site, like a brief intervention, and then if necessary, a referral into substance use disorder treatment. So the SBIRT model really, so we have again that, green is good. The red requires treatment. That person has a substance use disorder. Then there's that middle area, so binge use or problem use. That's the area that's, really the target for SBIRT that has been left out in the historical model. So this is about 20% of the population, 15 to 20%, that really wouldn't get any services. They'd kind of be missed until, the problem starts to get worse, and they might end up with the substance use disorder and then require treatment. So we're looking, this is more of a public health approach to identify problem use before it gets more severe. So now I just want to get into kind of the parts of SBIRT and the parts of suicide prevention and how they can be integrated together. So for screening, we talk about there are pre-screens. We know that different sites that are implementing these services are very busy, and we want to start off just with a few questions. So the audit C for alcohol, the DAS1 for drugs is typically, I'm only providing some examples here, but some of the more common pre-screening tools used for SBIRT. There's also the, we're familiar with the PHQ-9 for depression. There's a PHQ, and for pre-screens, a lot of us talk about the PHQ-2, which is the first two questions of that PHQ-9. But the PHQ-3 includes that last question, which talks about suicide. So that gives an indication of depression and suicide. So if someone says yes or answers positively to that last question about suicide, they would then get the full, they would then get the, actually I'm jumping to the end here, but get another suicide risk screen that gives a lot more information about the nature of the problem and what services should be provided. So the screening using standardized tools, if there's a positive screen on the pre-screen, we would proceed in SBIRT with substance use prevention and intervention to the audit in DAS-10. For adolescents, there's the CRAFT, which is very widely used. There's also the S2BI, which is also used pretty often for adolescents. And the CRAFT continually gets updated, based on what the current issues are facing youth. So the most current version is the CRAFT plus N 2.1, which also includes questions about vaping. So then we've got the full PHQ-9 for screening for depression. And then if someone is to screen to answer that they, so this last question of the PHQ-3 is a wish to be dead. If they answer positively to that, you would add the Columbia screen. So the Columbia screen I have here is the Columbia Suicide Severity Rating Scale, or the CSSRS. So it's commonly referred to as either the CSSRS or the Columbia screen. So you would add that for a yes response to that last question of the PHQ-3 or the PHQ-9. And for adolescents, the Columbia screen or the ASQ, which I'm going to cover both of them, can be used for adolescents. There's also an assessment. The Columbia screen could be followed by an assessment that can be found at the same by the same developers on the Columbia Lighthouse Project website. So I'm going to go over some of these screening tools and then what they mean. So the PHQ-3, over the last 2 weeks, how often have you been bothered by the following problems? Little interest or pleasure in doing things, feeling down, depressed, or hopeless, or thoughts that you would be better off dead or hurting yourself in some way. So if the patient is to answer positively to that last question, this is a passive suicidal ideation, that would trigger the Columbia or the ASQ. So the question, that I get a lot is, what do you do with a response like this? So that's the issue here, is that we don't really know the risk level here. If someone's saying that, they thought they would be better off dead or hurting themselves in some way, that is troubling, but it's not, and treating people with, suicidal thoughts or even just discussion about suicide can be, instill, fear in clinicians, and it's sometimes, thought of to send someone to the emergency department, the hospital, or whatnot, something like that. We need more information. We don't know the level of risk just with that question. So that would trigger a suicide risk screen like the Columbia or ASQ, which will give us more information about what we should do and how we should best treat the patient. So the Columbia screen, here I have on the slide the screen plus a color code of yellow being low risk, orange medium risk, and moderate risk, and red high risk. So the first two questions of the Columbia, so have you wished you were dead or wished you could go to sleep and not wake up? So this is very similar to the last question of the PHQ-3 in that this is passive suicidal ideation. And then the second question is, have you actually had any thoughts about killing yourself? So this is active suicidal ideation. So if someone answers no to question 2, you go directly to question 6. You always ask question 6. If the patient answers yes to you go and ask the rest of the screen. So question 3, have you thought about how you might do this? So that is asking about method. So if someone says yes to that, it means they have a method, and that puts them at a moderate risk level. If they haven't thought about how they might do it, they're still at low risk. Question 4, have you had any intention of acting on these thoughts of killing yourself, as opposed to you have the thoughts, but you definitely would not act on them? So that is intent. Do you actually have an intent to take your life? So that is high risk. The person intends on acting on their thoughts. Question 5, have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? So that is plan plus intent. Again, it's high risk. And then the last question is, have you done anything, started to do anything, or prepared to do anything to end your life? So in this example, you're asking about past 3 months. This is recent, and some of them ask about lifetime versus recent. So if someone has recent behavior, this is actually asking about behavior, that's high risk. That's the highest level of risk. So this is the interpretation of the responses. If someone's indicating a wish to be dead or having active suicidal thoughts, that's really just a referral to behavioral health outpatient. Once we get into the moderate risk, we're talking about a behavioral health consultation with a psychiatric nurse or social worker, and then to consider patient safety precautions. And once we get into the high risk, remember question 4 and 5 and 6 were in red. We're looking for the behavioral health consultation plus patient safety precautions. We want to make sure that the patient is safe. So the ASQ stands for Ask Suicide Screening Questions, and that's designed specifically for adolescents. So the Columbia is for both adolescents and adults, and this one is specifically for adolescents. It's a little bit simpler. It's really asking about, in the past few weeks, have you wished you were dead? Yes or no. And then in the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you had thoughts about killing yourself, and have you ever tried to kill yourself? If yes, how and when? So here you're getting into method as well as the recency of the behavior. If the patient answers yes to any of the above, then you want to know how they're feeling right now. You need to know whether they're having these thoughts right now. So this provides a good deal of detail on what to do based on the questions, how they respond to the questions. So if the patient answers no to all of them, that's it. The screening is complete. There's no intervention necessary. So we do often, underscore that a clinician's judgment can override that negative screen. Answering yes to any of the questions is a positive screen. And then question 5 is an acute positive screen. So that means imminent risk. So the patient can't leave until they're evaluated for safety. So when I say patient safety precautions, we're talking about keeping the patient in sight, removing dangerous objects, alerting a physician or clinician who's responsible for that patient's care. If it's a no to question 5, we're talking about a non-acute positive screen. There's potential risk there, so we're talking about, a brief suicide safety assessment, determine if a full mental health evaluation is necessary. And actually, I'm going to get into a little bit more information shortly about that. And something else that we like to underscore too is, and it's very similar to an SBIRT, where you want to provide something to everyone. So even when someone screens negative, you want to provide positive reinforcement. So with suicide risk screening, when a patient screens negative, negative or positive, but when negative, we want to provide resources to everyone. So we're calling, in New York State, we like to call this universal precautions. And we're talking about all patients being provided with the National Suicide Prevention Lifeline number, the crisis text line number. So we know that a lot of people prefer texting to talking nowadays. So the crisis text line is available to text with trained counselors 24/7 about many different things, not just suicidal ideation, but substance misuse, relationship problems, depression, anxiety, bullying, school issues, domestic violence, a lot of different things. It's as simple as this texting. Here, the example is home to 741-741. Though there's a lot of, that home is called a keyword. There's a lot of different keywords that can be texted. And I know in New York State we have got5 as our keyword. So you should check your state, see if there's any specific keywords that you can use to market the use of crisis text line. Also provided to patients is psychoeducation on warning signs of suicide and the fluctuating nature of suicide. So the idea is that suicide risk fluctuates, and we know that sometimes we're fine, and sometimes there can be something that happens like a foreseeable change that could greatly increase risk. So we know that if thoughts of suicide do come, there are these numbers available, or they can seek help. Now on to the intervention. So in SBIRT, we have the brief intervention. A lot of us like to use the brief negotiated interview, or BNI, which was developed for busy primary care settings that really follows a script that can be performed in 5 to 15 minutes, which has a number of steps, including building rapport, going over the pros and cons of use, providing information and feedback, using a readiness ruler to see where an individual falls on readiness to change, and how you could move up that ruler to be from less ready to more ready, and then developing an action plan that's driven by the patient or the client. Very similarly to a brief intervention for SBIRT, there's also a brief intervention for suicide risk called the Safety Planning Intervention, or SPI. This was developed by Stanley and Brown, so sometimes people call it the Stanley Brown Safety Plan, because we know the term safety plan is used quite a bit, and there are crisis plans that are not specific to when there is a suicidal crisis, and they just don't work the same as for a suicidal crisis. You can't really identify or create a suicide-specific safety plan that's not specific to that situation, because it won't, in developing something that's not specific for that high-risk setting, it won't work in just any setting. So the idea is that this plan be developed collaboratively between the patient and the provider face-to-face. So it's not just completing another form, it's actually an intervention. And the idea is to start off by introducing the safety plan, talking about how suicidal crises come and go. And this plan helps to prevent one from acting on these feelings. And very importantly, it enhances self-efficacy and sense of self-control. So the idea here is that, like I was saying a few minutes ago, it's the thought of a lot of times of providers who aren't skilled in suicide prevention to go to immediately to a high level of care. We want to make sure that individuals who have thoughts of suicide and who screen positive for suicide risk, that they're treated in the least restrictive environment. So ideally, we like to keep these individuals in the community, and the safety plan really provides that opportunity that patients can really handle a suicidal crisis on their own, thanks to this intervention. As I said here, they have self-efficacy and sense of self-control for being able to handle this on their own with the fluctuating nature of suicide. So a safety plan has 6 steps. Warning signs, internal coping strategies, social contacts who may distract from the crisis, family members or friends who may offer help, professionals and agencies to contact for help, and making the environment safe. So the idea of this is a step-by-step process. All of this is developed with the provider going step-by-step, identifying these, it's really directed by the client, and completing this and identifying, would that really work? What are the barriers to that happening? If you're, in this situation, what is that something that you would actually use? And really refining it as going along. So first, warning signs. The patient is supposed to come up with their own specific warning signs. So what do they feel in themselves when a suicidal crisis is coming on? Second, internal coping strategies. So it's what can the person do on their own to cope. It's really distracting themselves, like going for a walk or listening to music. Those are two examples. So the idea is that they resort to that first when they feel the warning sign coming on. If that doesn't help to mitigate the risk, then they go to number 3, which is social contacts who may distract from the crisis. So this is not to talk about the thoughts of suicide and getting help. It's to distract themselves. So maybe there's a friend that you can contact, you can call and just talk about what's going on, or talk about like some music that they like, just something to distract. If that doesn't work, family members or friends who may offer help. So this is those individuals you can call and say, hey, I'm really having a difficult time. I'm having thoughts of killing myself. That is what you would do. You'd list someone down there that can help you in that sense. That doesn't work. You have number 5, and that's professionals and agencies to contact for help. So you could have, if you're receiving behavioral health services, you could put your provider down, the number, or your primary care physician, or you could put down, it's really great to have the National Suicide Prevention Lifeline and the crisis text line there. And then the last one is making the environment safe. So this is reducing access to lethal means. So if someone is a gun owner, it's giving that gun to someone else to store in the meantime while you're having these thoughts. Or if there are pills, prescriptions in the home, you give those prescriptions to someone else so you don't have access to them. Because we know that there's sometimes a very short amount of time between that thought of suicide and acting on it, and now having the means there available can put time between the thought and the action, and could really be, could save a life, because we know that we can't access services that quickly. So the idea is to go step by step into through these different items here. And so this is what we would call follow-up and monitoring. So almost like the referral to treatment or returning for additional sessions of brief intervention. So the safety plan that I just discussed, plus structured phone follow-up here, has shown to be evidence-based and to reduce suicide risk. So this is kind of the suicide safer care protocols, which are widely used. So the structured phone follow-up occurs 24 to 48 hours after initial contact. So this time, once officially discharged from emergency department or some form of treatment, very high risk time. So this structured phone follow-up, it assesses mood and current risk. You can re-administer the Columbia screen and contact the crisis line if there's imminent risk detected. It also allows the opportunity to review and revise that safety plan. So sometimes when the patient tries to use the safety plan, you identify, well, that's not something I would actually use, or that's not someone I would talk to, or it didn't really work out well. That's the time to say, hey, I'm going to update this. And then treatment engagement. So to figure out, how do we have to problem solve obstacles to treatment, and then provide information again on available community supports. And then the idea is trying to encourage them to continue getting treatment, to get their consent for additional follow-up, set a call time, let the client know how they can initiate future care, and just to see whether they have been. So then these future calls, they can you can really determine whether they continue to get outpatient treatment. And then there are what are called non-demand caring contacts, which are postcards, letters, they can be emails or text messages nowadays, containing brief expressions of caring. So it's really just knowing that there's someone out there thinking about you. And something as simple as this type of postcard was found to be effective at reducing suicide among, it actually was among patients who refused further care but received these contacts. And then there's also, just the warm handoff to other levels of care and different suicide-specific treatments that I have listed here. I just wanted to end saying that it's really important that the patient has the safety plan with them at all times. And now everyone has their phones on them pretty much at all times, so there are some apps put to have the safety plan in them, the My3 app and the Stanley Brown Safety Plan app. And so even during the safety planning intervention, it's great that the provider helps the patient enter this while they're going along and creating it. All right, so with that, that's the end of my presentation, and I'm going to hand it over and take questions at the end. So thank you.
Hi, good afternoon. My name is Deborah Cox-Howard. I'm at the University of Arizona's Counseling and Psych Services Department, and I'm going to wrap up our presentation today. And I was asked to talk about some intervention and recovery programs addressing substance misuse and suicide among young adults. And I just in a highlight format, I was asked specifically to talk about some of the things that we do on our campus. And it's a lot. So I've provided my contact information at the end if anybody needs to get in touch with me for more information. So a couple of things I wanted to speak with y'all about this afternoon. This is the agenda. I'm going to give you a few statistics, talk a little bit about the increased risk due to alcohol and other drugs coupled with mental health concerns, and what the University of Arizona does with regard to prevention programming, and then provide you with some resources. So I wanted to kind of start out with this particular slide, which has 1,591 unique students during the 18-19 academic school year. We do a survey in counseling and psych services. I'm going to refer to us as staff from here on out. And we do this twice a year, and this is some information and data that we've pulled over the last 5 years. And as you can notice, with moderate suicidality, which has been talked about by my previous two presenters, you can see in the light blue that it's increased. There was a little bit of a dip in 16, 17, but it's increased again. And what we see a lot of that students are coming in and stating that they're feeling suicidal, they don't want to go on with life, some of the emotional pain that we talked about earlier, but also the number one thing that they're talking about is they feel stressed, they feel that they're not fitting in, they're comparing themselves to others, there's financial issues, there's pressure to succeed in school, they don't think they're going to be able to cut it, they go on and on. As you notice, the high suicidality, and these are the students that answered our survey, that literally we ended up having to hospitalize for a different level of care for suicide, and that's gone up as well, as you can see, from 14-15 to 18-19. This is some information that's taken from a health and wellness survey that's done by our health prevention and preventive programs. And this was done last year. with an N of 4,879 students. We go into classrooms and other areas to gather that information. And this information I'm about to give you is based on the respondents of 68.2%, so just over 3,000 students. And they were asked if they had used one substance, at least one substance, within the past 30 days prior to taking the survey. And the substances included tobacco, alcohol, e-cig, vaping, nicotine, or marijuana, cocaine, heroin, sedatives, prescription pain pills, stimulants, and ecstasy. And the findings related to substance misuse and suicide were that we found 11.7% of alcohol and other drug users versus 9.7% of non-users reported suicidal ideation within the past year. So you can see that it's higher within the substance misusers. Also, 2.4% of alcohol and other drug users versus 1.6% of non-users reported at least one attempt. So again, that's a little bit higher. 21.2% of alcohol and other drug users versus 17.1% of non-users have been diagnosed for depression, and 26.6% of alcohol and other drug users versus 21.2% of non-users have been diagnosed for anxiety. So I want to jump right into, just in the interest of time, some of the prevention programming that we do on campus for all of our students, but specifically in regard to substance misuse. And so one of our programs that we have, and we work in tandem with our health promotions and preventive programming, is QPR. Some of you may have heard of it. And it's question, persuade, and refer. We have trained people on campus that go around, and we've literally reached thousands. And it's an intervention that's designed to prevent suicide. We like it because you don't have to be a mental health professional to use it. And the techniques that are gained from this type of training offer hope, and they provide a method to take action. You figure, people around each other all the time, they're going to see signs before they may refer or show up in our offices. So this is just a way to be a gatekeeper, which I'll talk about later. Just a note, there are more deaths by suicide in the United States each year than by homicide. 10th leading cause of death overall, and second leading cause of death in 15 to 24-year-olds. 90% of those in suicidal crisis give some kind of warning sign to those around them, including substance misuse. That's the reason for training people to recognize the signs. And while you can't predict suicide, this technique helps to prevent it. Another thing that I wanted to point out is this is a brochure that was designed by myself and a colleague several years ago, and we keep updating it. And we pepper the campus with this, and it talks about basically it's someone suicidal. And I can't tell you how many times in the last 23 years I've been working on campus, literally people have said, hey, I wasn't aware that they were feeling that bad, or that they were actually going to do something like that. So several years ago, my colleague and I designed this brochure to kind of put it out there. And one of the things that we have on here is teeny tiny. Can't really read it on here, but on the back side, it has like some of the signs that you can be aware of, what to do if you're concerned about a friend, and we also have a list of resources. And this is a poster that goes along with this brochure. And, like we ask people to notice things like social isolation, feelings of hopelessness or depression. Substance abuse is definitely in there. Wrapping up loose ends, giving away important possessions, and a sudden change in mood. And again, we ask you to notice, care, and help. And we put some resources on there. Wildcats Anonymous is University of Arizona's Collegiate recovery program, and it was designed to help students that are in recovery stay sober, stay clean while they're in college, and also continue to have a positive college experience. The other thing is that we do have allies that participate in this particular group, and it's an on-campus organization. They work conjointly with our CAPS department. They do have 12-step meetings that they provide on campus. They look at different programming, and we do have peer mentoring for students who want to address their substance use, which has been very successful. Myself, as a clinician, I can talk to a student till I'm just about blue in the face. And, you know, when we say, hey, would you like to talk to another student about what you're experiencing, it's been quite effective. Also, we're committed to providing free activities that actively promote alcohol and substance abuse awareness. And we do this through many, many tabling events that we have on campus. And also, they participate in things like National Alcohol Screening Day, National Depression Screening Day. And so they're getting that information out there about substance abuse awareness. Or we provide alternative to activities commonly associated with alcohol abuse. For example, they might work to provide sober tailgating. They do things like go to escape rooms or zip lining so that they can have fun, have that college experience, but they're not using. Our allies are students that participate within Wildcats Anonymous that don't have any substance abuse issues. They just choose to be around people that are remaining sober. Another group that we have is our mindful ambassadors. And, you know, we know that stress gets in the way of optimal performance. A lot of times for students that are struggling with substance misuse, they may resort to using more because they're stressed out. So mindful practices are variable tools in a student's tool chest of stress-reducing techniques. And, you know, I love the definition of mindfulness, paying attention in a special way, consciously, without judgment, and with relaxation. And it helps the students to tap into their inner strength. Some of the things that, you know, someone was asking me the other day, like where we actually do all of these presentations, and we do them in the dorms, we do them for Greek Life, we do them on the mall, we do several events over the years, so we really reach large numbers of students, and we start a lot of times with their orientation. These are just a couple of crisis resources and hotlines. Anyone that comes into CAPS is given a resource list. It has a plethora of resources via online, by phone, etc., and tips to just stay safe in general. And we also provide hotline numbers to them. Some of these you've already heard about in earlier presentations. And then I'm encouraging y'all to check out our website. Like I said, there's so much going on. I can't do it in the time frame, but the gatekeeper training is what I was talking about that goes along with the QPR. And basically, we have people that have been trained to train other people. So it's a train the trainer situation. And we do have graduate students that have been trained. We also have clinicians that have been trained to go out and teach and train other people as to what to look for. This semester, we were just kicking off our Stronger Than program to help students to discover their strengths and build their own road to resilience. And that was kicking off right before COVID hit. And so we're still going forward with that, but everything is online right now. Our Active Minds group, which some of you may have heard of, they're a nationwide organization, and they changed the conversation around mental health. We do a lot of work with stress management and time management, because that's often one of the chief complaints of students is that they're stressed out, they can't manage their time, and they resort to substance misuse, along with sleep hygiene. Nobody's getting any sleep, and so we help them with that. Our friend-to-friend website is a place that students can log on to, and they can get information and advice that can help them to help a friend who might be experiencing problems. And literally, it's like they click on, and they may click on, for example, my friend is starting to use too many drugs, what do I do? And they have a step-by-step process that can help them doing on our campus for about COVID-19 and the resources for managing stress and anxiety during this pandemic. I put the website at the bottom of this. And so when you go, you're going to see these bulleted points. One of the things is to talk it out. And we have online and individual group counseling sessions at CAP. Like I said, we've moved everything online to read and listen. So we've put articles, we have guides, we've got podcasts and more. Watch, we have videos to help navigate through uncertain times. We have download and do, support for your mind and body. Let go, this is soothing music, guided meditations. Follow reliable resources for news and mental health. Take charge of your health and your well-being, and look and learn visuals and infographics. And like I said, if you click back on that, what happens is that you automatically link to all these different resources, because as we're counseling our students being Zoom, some of them are getting a little stir crazy. Some are trying to stay clean and sober, and they're still dealing with their mental health issues, and so we can provide these resources to them in that format. And that is my information. Please feel free to email me. That's the fastest way to get in touch with me, or you can call me.
Thank you, Deborah. There is a question for you in the chat from Angela asking if those findings were statistically significant. And I'm guessing that might have been referring to the student health survey. If not, Angela, please clarify in the chat. But I don't know if you can answer that question, Deborah.
Yeah, were these findings statistically? Yeah, I see the question. Angela, like I said, I think you were referring to some of the statistics that we gathered that I presented from our health and wellness surveys. And to answer your question in a word, yes, they were statistically significant. As I said, I didn't pull together all of the information that I was able to gather around that, but we compared it to other universities across the country and found similar traits and trends.
Great. So we're going to open it up to questions. If you do have a question for any of the presenters, if you could please put it in the chat box. So we do have a question from Sheila. Why are we seeing such an increase in suicides? I don't know if any of you want to answer that.
I can jump in there with that one. This is Deborah. I don't know if we're necessarily seeing an increase in completed suicides. I've noticed, and my colleagues and I have talked about this a lot, that students are coming in and they just have an overwhelming sense of hopelessness. I believe earlier Brett was talking about that they use a tool, the PHQ-9. We use a PHQ-9. Everybody that we see, they do a screening every single visit for depression, for anxiety. We do a suicide assessment, an alcohol and other substance abuse assessment, and also well-being. And for a lot of them, the students are just reporting just this overwhelming sense of they need to succeed, they need to be able to support themselves financially. They don't feel that they're going to be able to move forward. This whole thing with COVID hitting when it did, it's thrown a lot of them into feelings of hopelessness. And so it's more of the ideation as opposed to, yes, I have a plan, and yes, I have an intent. It's more of a thought of, I would just rather not be here and have to deal with this.
Okay, thank you so much. We have a question also from Casey. I am still unclear on a big issue. If a teen is cutting, does this necessarily mean they are at risk for suicide? I don't know, Brett or Jim, if you want to answer that one.
I can jump in there.
I can give.
Go ahead, Dr. Harris.
I was just going to say that self-harm it is a risk factor, so it certainly increases risk, but it doesn't mean that the individual is suicidal. It might just be, sometimes when people cut, for example, it's for relief. It's not the purpose of ending their lives. One of the things, though, that actually I should, Dr. Mazza, I should let you respond to this, but I guess how it goes into the theories that you were talking about and capabilities. I don't know if you want to talk about that.
Sure, I can jump in there. So, like Dr. Harris had said, that the self-harming behaviors is actually more frequent than the suicidal behaviors, and there are some people that engage in self-harming behavior and also have some suicide attempts. There's a lot more people, though, that engage in self-harming to gain control over that emotional pain that we talked about, or that I had mentioned. And so what we want to think about is that by cutting and engaging in self-harming behaviors, it focuses the mind on something else. It focuses on the physical pain, which actually is the emotional pain. And so because of how behaviors work, if we can reduce the severity of something, we tend to do that again because it reduces the amount of pain that we're suffering, just like the headache example I gave. And so they're going to engage in that behavior more and more. And I think that to what Deborah had talked about, at the University of Washington, where I teach an undergraduate class on wellness and resilience, we're seeing a lot of universal kids. So these aren't kids that get into the clinical settings or the student health settings that I think Deborah was talking about and Brett were talking about. These are people that are just taking their classes and they're feeling a bit isolated, even though they're on a campus of 50,000 people. They're feeling like people don't see where they're coming from. We know that from some of the research that's been going on with Matthew Knock and his group, that roughly 1/3 of all incoming freshmen have a mental health difficulty, and our campuses are just not prepared to deal with that high number of mental health needs. And so they feel more isolated, they don't know how to access the services, and when they do access the services, there's not enough personnel to provide services to them. And so most counseling services centers now in our universities and colleges do crisis management. Very few of them now have enough time to do some of the ongoing long-term therapy that we were talking about. So I think that there's a confluence of numerous things happening that are probably pushing up our numbers of not only those who are thinking about suicide. We know the numbers of deaths are increasing in that age group between 15 and 24 as well.
And Brett, this is for you, I believe. Can you explain the CRAFT 2.1?
Yeah, so the CRAFT 2.1, so there's all the different versions. There's the 2.0, there's the 2.1, and there's the CRAFT plus N that I was talking about, the vaping version. So it really, it has a couple of questions at the beginning that's asking about if on how many days there has been any drinking of alcohol, marijuana use and then other drug use, and then this that adds nicotine in with vaping. So the additions, the versions, the Craft Original, the Craft 2.0, the 2.1, they just changed the beginning questions to make sure that the terminology is used that's being used right now. And instead of saying, yes or no, have you, had a drink in the past, whatever, it's asking about days so that it's not biasing the response. So you don't feel like, a youth isn't feeling like they're being judged for saying yes. So that kind of was the reason for the change there. And then the remaining craft questions, C-R-A-F-F-T, car, relax, alone, forget, friend, trouble, what it stands for, is really asking questions about both alcohol and drug use that relates to those issues. So if someone hasn't used, if youth hasn't used at all, they will still get the car question, which is really asking whether someone has either driven while using alcohol or drugs or ridden in a car with someone who was, because there's also a driving risk and a riding risk. So it really covers those different issues, and there is an algorithm, usually a score of 2 and above is what's called a positive screen, which would then indicate a brief intervention. Of course, if someone scores a 1, there's still moderate risk and kind of a more brief advice. And then if someone is scoring a 0, really positive reinforcement is provided, and then just kind of some information about alcohol and drug use. And so the tool is readily available. If you kind of even just looked it up, it's available. And a lot of practices use it. It's a very easy to use tool. So definitely highly recommended for use with adolescents.
Great, thank you so much. And Jim, this might be for you. Barbara is saying, I noticed there was no information on support for someone who lives in a house of violence. However, all your information can be inferred. What do you say?
Yeah, so Barbara, thanks for the question. Living in a house where violence is taking place is really hard, and so I think Dr. Harris covered really well about having that safety plan. I would certainly go there first, and so that this person has a plan to be able to who to call, where to go to, some support that's there. Things that, oftentimes where there's violence happening in a home, the idea behind the perpetrator is to isolate that person, and we kind of want to do the opposite with that person if we're seeing them and try to provide them with support. And so I would also worry about that the violence, that somehow they're blaming themselves for the perpetration, right? That they're blaming themselves that they deserve this, it's because I'm not very good, that type of mindset or that type of thinking. And we want to kind of make sure we combat that with just some of the mindfulness exercise, that this person has a lot of value, that I am good, and that we try to promote their own strengths, even though the environment that they're in is probably what we call invalidating and very difficult to be seen as somebody of worth and value. So I think I would put that as part of the safety planning, and then what are they doing for themselves that keeps their self-worth. So I think that would be important.
Thank you. And then Andrea is asking, I work at a behavioral health hospital here in Las Vegas, and I noticed a link between homelessness and mental health. Can we explain to her why that is?
I can jump in there if you want. This is Jim again. So one of the issues that we have, so we know that our homeless population has a lot of mental health issues that are going on. Many of them are substance users or abusers at this point. They're also engaging in behaviors that they actually don't want to be doing, yet they need to do that to keep themselves alive. And so I think that there's some risks that are there. So they're inherently in risky environments. They're engaging in behaviors that don't align with their long-term values and goals, yet they can't see a way out of it. They're not sure where to go. Their home life might be violent. It might be very unfulfilling. It might be invalidating. And so they feel like the street is a safer place at that point. And what they're really doing is you're choosing between two evils there, right, or two difficult environments. And so I think that makes it really difficult. And so their exposure to others that have engaged in self-harming and suicidal behavior is also there. And if they're engaging in risky sex so that they can get money, that's also going to be something that's an exposure. So I think that those things cause quite a bit of emotional pain. So remember, that's at that center. And so if they're engaging in behaviors that don't align with who they are inside, and yet they don't have a good relationship with other peers as a safety net, then they're kind of falling through the cracks and don't know how to access the services, don't have any money to provide any long-term services. And so it kind of becomes a spiral of difficulties in trying to break that cycle. And so they may often engage in suicidal behavior that way.
And then I think this is probably a question for any of you. Are there always warning signs? Sheila is asking.
I would say that there are often warning signs, but no, there aren't always warning signs. And, this is in speaking with, individuals from the, who are loss survivors. They just say, after losing someone that they love, they're told that they're reading stuff and they're told about things and they're like, here are the warning signs. I didn't see any of those warning signs. There were no warning signs. So there are warning signs that you can find readily available, posted on suicide prevention websites. We have them on our website, preventsuicideny.org. But yeah, often there are definitely times where there are no warning signs.
Thanks, Brett. And Stephanie's just making a comment here. I think we are going to truly find out how broken the system is with all the COVID-19 outcomes. So I think certainly I know some of you have addressed that.
This is Jim again. Anecdotally, we're seeing an increase in crisis line calls here in Washington State. And if we think about COVID-19 and we go back to Thomas Joyner's model about thwarted belongingness, COVID-19 is thwarting a lot of people's ability, especially our young kids' ability, to belong. And when we look at the situations now for our seniors in high school, our seniors in college, where these are supposed to be celebratory things, and they're being told that they can't do that, it kind of weighs on them. It's not something that is, they're viewing it as something that's going to be this real positive occasion, and now it's almost like a stress that nobody's going to recognize some of their large accomplishments and significant accomplishments. And so I think that we're going to start to see some COVID-19 kind of stress accumulations happening, and I think that's going to kind of pour a little bit of gasoline on some of the mental health fires that are going on for some of our people.
I would absolutely, this is Deborah, I would absolutely agree with that. I would absolutely agree with that statement. We've already been seeing an uptick in people utilizing our drop-in services, and a lot of them have never been seen before. They didn't have concerns of mental health, but we have graduate students that they're grieving. They've worked very hard for their degrees, and they're not able to go to their hooding ceremonies. For some, they have jobs that have been put on hold. I have several seniors that are graduating, and their next steps have been pulled away because they're not going to be going to that internship, et cetera. Even just the idea, our campus has been closed for just over 2 months. So imagine being on spring break and you're getting ready to come back from spring break and seeing all your friends and participating in activities, going to school, wrapping up your semester, getting ready for your study abroad program, and you get a text saying that spring break has been extended by 2 days, and by the way, when you come back, if you're living on campus, you need to get your belongings and move off campus. And this is what's happening. Everything is going online. And not knowing the definite end is or what it's going to look like. The uncertainty is starting to weigh on a lot of people. So I definitely agree. It's going to be an interesting couple of months.
Right. I mean, a lot of people in the chat agreeing with you both, and also seeing those same kinds of increases in calls, and a lot of concerns with what's happening with COVID-19. There are some good comments in here, and some resources as well. So I'm going to go ahead and move us along. I want to just mention some upcoming events from both of the TTCs. So make sure you mark your calendars. We do have a two-part webinar series coming up from the HTTC on demystifying data, gathering and using local risk and protective factor data for prevention. And we're doing a part 1 on gathering data on June 4th. And then part 2 is on using data. That will be on June 18th, and those will both be at 3 p.m. Pacific time. The mental health TTC also has a number of things coming up in honor of Mental Health Awareness Month, which is this month. So starting tomorrow with a webinar on shining a light on Asian Pacific Islander mental health in times of COVID-19. And then on May 18th, they are featuring a webinar on leadership in times of chaos. May 19th will be a focus on self and collective care for healthy workplaces. And then on May 26th, please join them for a webinar on well-being through crisis emotional PPE. So a lot of COVID-19 related opportunities here for you all to take advantage of. Here's some information for the Mental Health TTC on how you can contact them. You can visit the email here, their website as well. They have a newsletter there you can sign up for. And then here's just my contact information for the PTTC, and you can join our listserv as well. So we do have just a couple of minutes. I thought I did see a couple more questions in the chat. I thought we could maybe try and squeeze those in. And there is a question from Gail saying, have any of you heard of, she's got a friend who is a behavioral specialist, said that after being in ICU, a lot of the patients come out with a type of PTSD. Have any of you heard of this? She's asking. And she's wondering, oh, I think she's referring to, there was a doctor in New York who committed suicide. She's wondering if she may have had some form of PTSD. So I don't know if any of our presenters want to respond to that.
I'll respond. I'm from New York, so yeah, we're you know, I work in suicide prevention. We are made aware of that right away. It's a very big problem among frontline workers, and PTSD is a major concern. Mount Sinai in New York City is opening a new center that's specifically for frontline, you know, the issues, mental health issues around COVID-19 for frontline workers, and the idea that there is likely, you know, going to be PTSD from this, and what the implications will be. And they're going to be doing some research, and there'll definitely be some information that's coming out of that. So also, you know, we're in New York State, where there's a task force that we put together, and we're going to kind of see, you know, how we can best address this.
Great, thanks, Brett, for answering that. And I want to remind everyone you will be receiving an email with the link to our evaluation. So we do really appreciate your feedback on the webinar today, and we really encourage you to fill out that evaluation and let us know, you know, how we can improve future webinars. We do really appreciate hearing from all of you. So I want to thank our presenters again today for joining us on today's webinar, and thank all of you who joined today. And we really appreciate your participation. There's a lot of great resources that have been put in the chat. So thank you all for doing that. And thanks again, and have a great rest of your day.